Great. Welcome again to another episode of our Focus on Facebook Live with myself, Dr. Husnain Kermalli, Chief Medical Officer here at St. Mary's Hospital in Waterbury, Connecticut. Each month, we'd like to highlight one of our clinical departments and want to give you a little bit of insights into the services and the expert providers that we have here at St. Mary's Hospital available to you in the community. February, of course, is recognized as the Heart Month. We just finished Valentine's Day yesterday. And so today, I'm glad that we are focusing on our cardiology services here at St. Mary's. Our team here is part of a regional team as well, managing multiple complex diseases and true leaders in cardiovascular care. We manage everything, common to complex. And so today joining me is Dr. Rebecca Scandrett. Thank you very much.
Thank you.
Dr. Scandrett is an interventional cardiologist with a practice here at St. Mary's Hospital in Waterbury, known for her compassion, patient-centered care, and expert delivery. So thank you very much and welcome.
Thank you for having me.
My pleasure. So interventional cardiologist, tell us what does that mean? What do you do?
So an interventional cardiologist, in my role, is I do invasive procedures, namely cardiac catheterizations and percutaneous coronary interventions. Some interventional cardiologists do branch out even further into the realm of structural heart disease, namely valvular heart disease and percutaneous repairs or replacements of valves. I personally do not do that. I stick in the coronary world. And what that means is if, for kind of in lay terms, if someone has a blockage in their plumbing, so a blocked heart artery, which often manifests as chest pain or could potentially on the other end of the spectrum manifest as a heart attack, I essentially will go in, take some pictures of the heart arteries in a minimally invasive approach, and ideally be able to fix the blockage. So kind of like your plumber goes and fixes the clogged arteries, your clogged pipes, I go and fix your clogged arteries. And ultimately, we'll kind of prop open the artery with a stent.
So you make it sound so easy.
Well,
except the difference in my mind when the plumber says, well, I do the same thing, they're not doing it while the plumbing is running.
That is true. That is true. So, we have a lot of great techniques that we can use. And just in the time I've been doing this, although I just realized today that it's coming up on 15 years I've been doing this, which is a little horrifying that I'm that old. But, the techniques have evolved and are continuing to evolve. It used to be that we had to access the arterial system through a big artery in the leg called your femoral artery.
Right.
We still use that. That's still our backup.
Sure.
But I would say 90% plus of the time, I am able to do my entire procedure through just the little artery here in your wrist.
Wow.
Literally, it's a little pinhole. Patients kind of come to me, the next week and follow up and say, how did you do that? And it is kind of cool. Luckily, the heart doesn't move too far. It sort of is beating, but it's not running away from me. So.
Well, that's good. No runaway hearts.
Yes, no,
at least on your
no.
table. Good, excellent. And that's true because when my dad, who came to our service, had to be taken care of, very similarly through his vein. Yep. And I was astonished. I was like, wow, that's pretty cool. Because we all thought it was regular leg type of thing, but it's truly evolved in that field.
It really has, and it's so much nicer for the patient because when we are successful in getting up through the wrist, and I never promise that to anyone, but when we are successful, the patient can sit up immediately after the procedure.
Right.
When it's through the leg, we really have to be a little more cautious with bleeding, so they have to lie flat for a longer period of time. It's just, in general, a much more comfortable procedure for the patient, and much less bleeding complications, which is great.
Yeah, absolutely. So let's take a step back from interventional for a second. Let's talk about what we are able to offer from cardiovascular services here at St. Mary's.
So, for a small hospital, we offer a lot.
Yes.
We really do. I work with a group of fantastic cardiologists. Hopefully they're not hearing this because I don't want their heads to get too big.
They are fantastic. They are fantastic.
They really, I'm very blessed. I have a great group that I work with. So we really run the gamut. So, the foundation of any cardiology practice, I don't exist without my partners. Mm-hmm. So, we do at our heart is consultative cardiology. So both on the inpatient and outpatient settings. So anyone, either inpatient or outpatient, has some sort of cardiac complaint, chest pain, palpitations, shortness of breath, passing out, anything that their primary team or doctor feels could be cardiac related,
right,
we will see. So that's where it starts. We have one big office in Waterbury. Actually, we have several offices in Waterbury now, but we really are expanding. We have locations on West Main, on East Main. Yep. I'm now seeing patients in Cheshire, which is wonderful to be back there.
Yes.
Especially since it's down the road for me. So, we really are kind of expanding out there. So, 5 days a week at multiple offices, we have multiple docs seeing patients. From there, we do all sorts of non-invasive testing, depending on kind of what our assessment is. And that ranges from echocardiograms, which is ultrasound of the heart. Stress testing, both just plain treadmill stress tests as well as nuclear stress tests,
yep,
which are non-invasive ways to look to see, do we think there is a plumbing problem? Is there a blockage? Not looking at the arteries themselves, but looking at surrogates.
Yep.
It's a very good non-invasive screening test. We do arrhythmia monitoring to look for patients who are having palpitations or passing out, and that can range anywhere from a 24-hour monitor to 48 hours to 2 weeks to 30 days to an implantable monitor, mm-hmm, that we can do that can monitor you up to 3 years.
Yep.
We do my services in the cath lab, where we're doing diagnostic and interventions on the coronaries. One of my partners is doing structural heart disease and, mm-hmm, really has taken the lead on percutaneous valve replacements. That is done at St. Francis, but we sort of do all of the work up here at, yep, St. Mary's. My other partner is more on the electrical side and is putting in pacemakers and defibrillators. And then with our colleagues at St. Francis, we have some heart rhythm specialists, electrophysiologists, who come here and will see patients in consultation and are doing both some arrhythmia ablations, so atrial fibrillation ablations, supraventricular tachycardia ablations. So I'm the plumber, they're the electrician. They take care of the electrical side of things for us in our more complex arrhythmias. And I guess we also, I forgot, have a new partner again based out of St. Francis, but who's coming here, who's looking at, I look at the heart, he looks at the arteries down the rest of the body, so peripheral vascular disease. And we have a clinic offering there where we are looking for signs of peripheral arterial disease non-invasively, and if needed, to do interventions. And our heart failure clinic. I keep forgetting. We're expanding right, left, and center.
And I mean, you're bringing up a great point, because we have this connection with our sister hospital, mm-hmm, up at St. Francis, part of the Trinity Health in New England family, where we have these other services, yep, that are available. So let's talk about heart failure you were about to mention.
So, we have a great group of heart failure specialists based out of St. Francis who we're now running. Gosh, you're probably going to have to correct me. I believe it's once a week, mm-hmm, where they are, we're really trying to get the patients who've come into the hospital with heart failure, and we're trying to get them an appointment there where they can spend, 2 hours with the patients, yeah, making sure they're getting the services they need at home, making sure they're getting the medications they need, because often these medicines are very expensive. And it takes a lot of time to make sure we're getting them what they need.
Yeah.
And then making sure they're getting the appropriate follow-up. So it's a really great extension of my group, because they can spend those 2 hours and then they contact us and let us know kind of where we need to, what holes we need to plug.
Yeah. And that team is only going to continue to grow.
That's our hope, yeah.
Which is phenomenal. So in a small hospital like ours here in Waterbury, we're able to run that entire gamut of services that are provided for patients right here, which is remarkable.
Yep.
Let's talk about, so everybody's always excited about new and fancy stuff we were talking about. You mentioned structural heart disease. Mm-hmm. Or outside of that, and you did talk about the new radial artery access. What are some of the other newer techniques that we're using in cardiology here?
So, I mean, I think it's kind of just an expanding field. I know some of the electrophysiologists are putting in some of the leadless pacemakers. We're using, again, at St. Mary's, we have the ability to put in something called a percutaneous left ventricular assist device, LVAD, which is an Impella for our really sick patients who need support in how their heart's pumping. That is often a bridge to either get them through a percutaneous procedure, or sometimes it is necessary as a bridge until we can get them to higher level care to get the more advanced care and life-saving services. We do have a team, again, coming from St. Francis for our even sicker patients where they can do ECMO, and then those patients are typically cared for at St. Francis. We get them stabilized here. We have a wonderful cardiothoracic surgeon here who's doing,
Dr. Preisler.
Yeah, Dr. Preisler. I mean, he's
great.
He's just wonderful, and so much experience. So, from the most, kind of bread and butter cardiothoracic surgeon, coronary artery bypass grafting, valve replacements, to the really kind of, in the past few weeks, we've seen, just cardiac masses. Not 100% sure what they are. Resecting those, aortic aneurysms, all of those types of procedures. I'm trying to think other kind of new, and then obviously in the realm of structural heart disease, TAVR, MitraClip is just being introduced. Again, we sort of screen patients here and they are going to St. Francis for these PFO closures, Watchman devices.
Right.
All of those are in sort of that realm.
And each of these are remarkable because they're taking that cutting edge technology and bringing it directly to the patient.
Yep.
So we're getting the patients ready here, we're sending them to the Center of Excellence to get the procedure, and then they're coming back for follow-up in our neighborhoods.
Yep.
So, it's sort of similar to going to Boston, except it's right here in the Connecticut region.
Yep.
So let's get a little bit of education for our viewers. Common conditions. We just finished the winter. Maybe we'll see what February and March looks like, depending, I guess, on what the groundhog said. And we had a little bit of snow outside. What are some common conditions that we see, signs that people should be aware of, or maybe even some of the uncommon signs that we want to think about?
So, as I've said multiple times, I'm a plumber. Number one killer is coronary artery disease. And that can really run the gamut of stable coronary artery disease all the way up to an acute myocardial infarction or heart attack. Some of the signs that you could be developing plumbing problems, blockages in the heart arteries on that more stable end of the spectrum. What I tell people is, typically, if you read the textbook, it is a predictable discomfort that occurs with some level of exertion and resolves when you're resting. Your heart's what I tell all my patients is your heart, I think, is the smartest organ you got. All right. So your heart can sort of acclimate and accommodate blockages in your heart arteries up to 95%. Mm-hmm. So when you have a 95% blockage and you're sitting here relaxing or watching TV at home, the demands on your heart are really low. And the blood supply, even with a 90% blockage, is able to meet those demands. You get up and go outside and shovel the snow, which I do not like people to do. I even tell my husband, no snow shoveling. That when you do that, the demands on the heart go up. The blood pressure goes up, your heart rate goes up, which it's supposed to do. And typically what happens when the demands go up, the supply goes up. The blood flow increases to meet those demands. However, if you have that 80% blockage in your heart artery, you can't increase the supply enough to meet those increased demands. And so what happens, the way you know that is, you start shoveling snow and I have this heaviness or a pressure. Oh God, I'm messing up my mic. Heaviness or a pressure squeezing in your chest. Sometimes it's a discomfort or a heaviness in the neck or jaw. Mm-hmm. Sometimes it's a little nausea. Sometimes it's shortness of breath. It could be burning sensation. Everyone's a little different. It's women's supposedly present with a little more atypical symptoms. It can be a little more sort of, I just felt a little nauseous when I walked and it went away when I rested.
Right.
But it's that predictability that sort of grabs my attention. So you get the symptoms when you're running up 2 flights of stairs, you stop running, okay, after a few minutes the symptoms go away. Mm-hmm. Clearly, if you're out shoveling snow, and you feel like an elephant sitting on your chest, and you're sweaty, and you're nauseous, and you feel short of breath and woozy, that's a sign that you've gone from that stable syndrome I was just talking about to an unstable syndrome or a heart attack. And what happens with a heart attack is a plaque that's developed in the heart artery becomes unstable and ruptures. And so you've gone from, let's say, a 40% blockage. That plaque ruptures and a blood clot forms there. It's like you've cut your skin, and the way you stop bleeding is blood clot forms. That's great on your skin. It's not so great in your artery because that blood clot forms and acutely blocks off that blood flow. So supply goes from here to here. And that's what causes a heart attack. When that happens, number one thing you do, or your spouse or your loved one, is you call 911. Do not drive yourself to the hospital. You call 911. The second thing you do is you chew 4 baby aspirin, and then you just wait.
Wait for the ambulance.
Wait for the ambulance. Don't get in the car. Yep. That is important.
That is very important because that ambulance is what's going to get you here right away.
Yep.
And is going to protect others, because if anything else happens along the way, we want other people to be protected.
Exactly.
Yep.
Exactly.
Alrighty. Well, I mean, those are great words. We came out of wintertime. Hopefully we're not going to see that any more snow maybe. Sorry for all of you viewers who love skiing and snowboarding. But thank you very much. And one other piece I wanted to ask you specifically. One of the other days that we have in February is actually National Women's Physician Day. And so thank you, number one, for being a woman physician. I think it's such a step in a positive direction overall, and so congratulations for that.
Thank you.
But can you give, I've got young daughters, one of them who's really interested in becoming a physician, or for some of our viewers there, what's your perspective on females in the physician role?
So I think we're great. There's more and more women. In cardiology, it's still a male-dominated field, which is fine. You go into it because you love it, not because of anything else. Sure. It definitely takes some juggling if you want a family and kids. I am unbelievably blessed that I have a partner and a spouse who is the most supportive person in the whole entire world, so that we both are able to pursue our passions. When I came here, almost 8 years ago, it was actually very nice. The newspaper did a whole article about how I was the first female cardiologist in Waterbury.
Wow.
Which was wonderful. It was awesome.
Yeah.
Although I think we will know we've made it, I'd rather be known for being the best cardiologist, regardless of gender, as opposed to being a good female cardiologist.
Right.
And I think that's when we're going to know that we're all good, that gender really doesn't make a difference, and it shouldn't make a difference. I think as you're looking for a doctor, you have to find that person that you sort of connect with, and that, takes the time with you and melds with your personality and your needs. And sometimes that's a woman, sometimes that's a man, and sometimes it's just, I think person to person dependent.
Yeah, no, you're 100% right. I'm confident you're a great cardiologist, period.
Thank you.
And that's the end of the story.
Yeah.
Great job. Thank you so
Great.
much.
No problem.
And again, thank you for everything that you're doing all the way across for taking care
Absolutely.
of our patients. Thank you very much for joining us on Facebook Live. Look forward to our next event in March, where we will be focusing on some emergencies that are going on. Thank you very much.